John, the floor is yours.
Good afternoon, Habib and Kais, and thank you again very much for inviting me to talk. It's always a great pleasure. So this session is from London, and just to be absolutely transparent, the way that we're going to run this is to discuss the coronary sinus reducer, which many of you will have heard of, some of you may have used, some of you may not have used. I'm going to briefly outline the rationale for it and then present a recorded case. And then we'll have, if we have time, we'll overview some of the evidence. But that's the way the session will work. And I'm going to invite my the panel to interrupt me and stop me as we go along to ask questions so that it's as interactive as possible. So let's see how this runs. And I'm just going to sort of share my screen to begin with to briefly overview things. So hopefully that's visible. So I'm just going to outline the rationale for a use of this rather odd device. For many people, this seems an irrational way to treat coronary artery disease by stenting a vein. But hopefully I can convince you over the course of the next few minutes that it is a very useful device in a wide range of patient populations. I've no conflict of interest in relation to this particular presentation and talk. So the first thing to say is that we're very good at treating our patients who have stentable or revascularizable coronary artery disease, but there's a significant population in whom we cannot satisfactorily revascularize them and are left with intractable symptoms. Now, these are European data, but about 7% of the population suffer from angina symptoms. About 14% of these, and maybe slightly less over the last 5 or 10 years, cannot be revascularized. That may be because they have unsuitable targets or distal disease, or they have diffuse disease which cannot be stented or bypassed. And about 10% of these develop refractory angina. That's a significant burden and a significant number of patients within Europe each year, 30 to 50,000, and a similar number in the US. So it is by no means a small problem. And actually, it's fairly stable. So if you look at the outcome for patients with refractory angina, they do pretty well. So this is not the same as your proximal coronary left main disease, in whom survival is adversely affected by the burden of coronary disease. Most will be alive at 1 year, although there's a proportion that won't. About 3/4 are still alive at 9 years. So we have our standard medical therapy. We've got new anti-anginas, which I'll talk about briefly in a moment, and they certainly have an effect, but there's definitely a place for additional therapies. Now, the sinus reducer is one of them. There are others, such as extracorporeal pulsation. But just to briefly look at this, I don't want you to go into too much detail in this slide, but we're really talking about two methods for treating, two approaches for treating refractory angina or even angina. One is to reduce oxygen demand, and of course we have a whole host of medical treatments for that, including our standard oral anti-anginals. And we've also got the newer agents such as ranolazine and also trimetazine, a slightly older agent we still use. I'm really talking about treating the supply here. So obviously bypass surgery and PCI are the techniques that we're familiar with, that we use every day. We don't use, but we send patients for bypass surgery every day. What I'm going to just briefly discuss is the idea that backflow, coronary sinus blood flow, is of potential importance. And this is not a new concept, but essentially what we're talking about here is the drive between the endocardium and the epicardium, so the ratio of blood flow between the two. So refractory angina tends to occur when there's a reduced ratio between the endocardium epicardium, so there's a pressure gradient that's not met by demand, and that patient gets angina. It's that which we're treating with the coronary sinus reducer. So in doing so, we are increasing coronary sinus pressure and increasing the endocardial pressure and reducing that gradient. And that is what we are thinking about. We're talking about the coronary sinus reducer. It's not a new concept. So this chap here, Claude Schaffer-Beck, you may or may not know, was one of the pioneers of cardiothoracic surgery in the 50s. He was the first person to defibrillate a patient. He was nominated for the Nobel Prize, which he didn't win, for medicine. He worked at the Cleveland Clinic, and he experimented with humans in the 50s. I say experimented, a small study of humans in the 50s, where he ligated the coronary sinus with the view to increase this back gradient within the coronary sinus, and therefore reduce the gradient between the endocardium and the epicardium and treat symptoms. So this was obviously surgical at the time with ligature without bypass surgery. And a comparison of 185 patients showed at that stage, 1955, relief of angina symptoms, improved functional class, and resolution of symptoms. Now, the mortality was higher than we would expect in current practice, but is still relatively low considering it's the 1950s. So again, this technique was largely forgotten about until very recently, with the developments really by Shmuel Banai in Israel of the percutaneous coronary sinus reducer. And this is a picture of it here. This is an hourglass shaped stent placed in the coronary sinus, which is there to increase pressure, coronary sinus pressure, therefore increase pressure back into the distal microvasculature and reduce the gradient between the epicardium and the endocardium, with the theory that it would relieve angina. Sounds a little crazy. It sounded a little crazy when we first heard about it. But essentially, I'm just going to move on, having briefly outlined that, to the clinical case we're going to look at today. So this is a very typical reducer patient, I have to say. This is a 70-year-old man with diabetes and high blood pressure, previous bypass surgery with class 3 angina. He's got a very strongly positive stress echo with 4 segments of anteroapical reversible ischemia, but overall good left ventricular function. In fact, you find, as you all know, it's the patients with good ventricles that have the most symptoms, and diffuse residual distal LADs and some residual right and circumflexes, which we will see. And I think it's worthy of discussion about how you might treat this patient without the reducer. This is his coronary angiogram. You can see the left system disease here. There is some, long OM disease seen on the angiogram, occluded LAD and a large diagonal, and this is a further view of that diagonal and obtuse marginal disease. And here we have a blocked, chronically occluded right coronary artery, vein graft to the intermediate, and then the lemma to the LAD, which shows rather diffuse distal LAD disease. So this man primarily has ischemia coming from the distal LAD. It's really not suitable, I don't think, for covering with stents. It looks moderately atheromatous. So this is an ideal candidate for coronary sinus reducer. So I'm going to just pause my presentation there and just run over to the video, if I can just share that now. Let me just bring that up. But before I do that, I wonder if there's any questions or comments from the panel about the appropriateness of the case or not.
While you are preparing your video, let me introduce the panelists that we have. Yes, we have Ziad and Samir Hania and Ziad Bilhaj. So if you have any comments, maybe, or short question,
please go ahead.
Please.
Okay. Well, I will maybe get on and start the video. So this is courtesy of my colleague, Professor Tommaso Mori, and I will commentate on the case as we go. So the first thing to say about the sinus reducer case is, firstly, that they're extremely straightforward. What I would say is that throughout this video, if people want to stop me to discuss things, that's entirely fine. So stop at any point to question techniques, methods exactly that were used. We're just going to show the device here unmounted on the balloon. So you can see this is a fairly large delivery system, 9 French, with the balloon crimped and mounted on it. There's the device there, which is hourglass shaped, stainless steel cobalt chromium frame, classical shape. So the first thing to say about setting up for the coronary sinus reducer is you need to set up your cath lab in a slightly different way. So access is from the right internal jugular vein, and therefore that becomes slightly less ergonomic when you're in the cath lab doing the procedures, because the screening is obviously all adjacent on the right hand side. You can see here, this is a typical orientation of the cath lab. Now access is right internal jugular, usually ultrasound guided, once in a 9 French sheath, and the sensible thing to do here is obviously choose the right catheter and engage in the right coronary sinus. Now, many of you may be familiar with right coronary sinus injection or intubation if you're doing EP procedures or if you do CRT devices, but that's not common for many of the interventional cardiologists. So there was certainly a learning curve in how this is cannulated successfully. The best way to do that is with a multi-purpose catheter and a standard 035 guide wire, which is used to gently explore the origin, the ostium of the coronary sinus. Procedures covered with unfractionated heparin, usually 5,000 units. You can see here, Tommaso's easily wired the coronary sinus. That's not always the case. So one of the issues is the anatomical variability of the coronary sinus and the presence of valves within it, which can certainly limit how easy it is to cannulate. And if one can't cannulate with a multi-purpose or have enough support with a multi-purpose, you sometimes need some of the specialty P catheters to get in to the origin of the coronary sinus. Now, once you have your multi-purpose in and the wire in, there are two ways to approach how you deliver the system. There's a standard 9 French delivery catheter which is used, and you can either set up to begin with that so that it's telescoped. There's a telescope mother and child system with a multi-purpose loaded into the delivery catheter, or as in this case, you can access the coronary sinus with the multi-purpose and then cut the end of the catheter. And then with the cut end of the catheter, feed that back through a 9 French delivery system. So I think that's what Tommaso is doing here. He's going to cut the end of the multi-purpose, remove the wire, and then reinsert the system with a 9 French guiding sheath. And the advantage of going with a 9 French guiding sheath and the mother and child system is that it gives you a lot more support. Now, the anatomy of the coronary sinus is also important. So two things one needs to make sure. One is that it's large enough to accept the reducer catheter, and it needs to have a dimension in its more distal course of about 3.5 millimeters. You need to have enough landing zone from the ostium of the coronary sinus, which is usually 1 or 2 centimeters. And you need to have enough distance beyond that so that you can wire it successfully. And as I said, the anatomy is sometimes very variable, so wiring of this can be tricky. So what Tommaso is showing here is the 9 French delivery catheter. Now, we have used some of the EP catheters to do this. They've got a slightly different curve. It depends largely on the anatomy of the sinus, how difficult it was to wire. And I think the key thing to mention here is that keeping things in place, particularly the wire and the multi-purpose, are essential to ensuring that you can deliver the coronary sinus reducer. So here he is feeding the 9 French delivery catheter over the system, which you'll telescope into the coronary sinus. You'll see that moving now around and into the origin of the coronary sinus. This can be difficult to deliver across valves, and it's very common for the coronary sinus to have at least one valve in the middle. It can be extremely hard to get kit across the valve, and you can see there's some resistance where I think it's moving across a valve. But it's essential that that catheter, that delivery catheter, is as distal as you can get it, simply because delivering the sinus reducer through that can be tricky. So you want to get that as distal as you can before you remove anything. So again, understanding the anatomy and how it behaves is quite important. But really, once you've cannulated the sinus and have the device in, it's extremely straightforward. And I say that we have had a number of issues in cannulation, and in fact, with some variable anatomy, once you're in, it is usually fine. Now, a few points about the sinus reducer itself. It's important to check that it's crimped adequately onto the balloon. I think it's analogous to some of the first generation stent technologies, where the crimping process and the balloon are slightly first generation. So it's very, very easy for the device to come loose from the system itself, and very important that you are careful that it has not moved outside the markers before you put it in the patient. We've had a number of cases where the device has come off the balloon. We've had to snare them back. So it's very, very important that part of the procedure is carefully monitored. Now, I think you need an assistant to fix your wire that knows what they're doing. It's a little bit like in structural interventions. There shouldn't be any movement on that wire. But then you can advance the reducer, which is on an over-the-wire system, and is prepped in the same way at the end with negative pressure once the device is in place. only when the device is in place. So just prep like a normal stent without negative pressure until you're in position. You can see here he's feeding the device through the delivery system. The distal two markers are where the stent sits, and there's a more proximal marker which you need to withdraw your guide catheter to. Now, the key thing in deploying this device is that you always move the system and the device forward together. You should never really move the device forward if you can avoid it, and not move the delivery catheter at the same time, because the device can easily become dislodged and lost. You need to see that you are proximal with your delivery system and that the device is not moved. In terms of landmarking, when we take the coronary sinus picture at the beginning, we will landmark to one of the vertebrae, which you can see here. And now that he's in adequate position, he's going to inflate. This is going to inflate the stent at 4 atmospheres. You can see here there will be a mid-waist, as you expect. The balloon will inflate distal to proximal, as you can see here, with a waist on the balloon, and that's up at 4 atmospheres. And you keep it up until it's maintained pressure. One of the key things here is removal of the balloon. It's a baggy structure which does not move back easily. So in removing the balloon, you have to telescope the delivery catheter over the uninflated balloon to the origin of the stent, so that you can exert pressure on the stent to remove the balloon. But it can be really quite tricky to do that. Before removing, you can take an angiogram which tells you that the stent is adequately positioned. It's always good practice when having removed all of the structure, to take an angiogram distal to proximal to ensure that you've got no major anatomical problem like a dissection, although these will usually heal. And here the difficult bit is removing the balloon carefully. And as I said, I tend to push the delivery system all the way in, often up to the wasted segment of the reducer, to pull that balloon out, leaving the wire in place in the distal coronary sinus. So this is really at the almost completion of the procedure. So I would remove the balloon and then reinsert a multi-purpose catheter. You can see there you often have to put quite a lot of negative pressure on the end of the balloon to try and remove it successfully from the catheter. And then he will insert a multi-purpose over that system to take a final angiogram.
John, if I have any comment, maybe.
Yes.
What type of imaging do you need to see the anatomy of the coronary sinus, or maybe to size the stent? Which one? Do you do angio with a light injection, or?
So we would just do angiogram with LAO injection in the setup. The majority of cases, the anatomy is very rare that the coronary sinus is not large enough to take a reducer device. In fact, more often than not, what we've been doing recently is not pre-planning with any angiogram beforehand. If you bring the patient in for the procedure, you can take a shot of the coronary sinus on the day. You don't need complicated CT scans. You don't even need complicated pre-procedural angiograms. It's very straightforward. You can do 5 or 6 of these cases in a day. They're very, very quick. They take 10 or 15 minutes. This is almost in real time. So it's not at all complicated. And the complications that we have had, as I've said, have been dislodgement of the device. So in the process of pushing the device forward to deploy it, moving the device off the balloon is a risk. And the other thing, of course, is access. Bizarrely enough, access in the right jugular we've sometimes struggled with, even with ultrasound guidance. So It is ergonomically different from how we run our catheters. I'm sure that you have more experience of jugular procedures, but we don't. But that's been the main limiting factor. But it is a very, very straightforward, very quick procedure. Complication-wise, I'll show you the data shortly if I have time. It's really low risk. Even if there's a dissection within the coronary sinus, it usually heals. We haven't seen any major issues with blood flow, etc. So I think from a safety perspective, it is a remarkably straightforward procedure. So I wonder if, before I come back to my presentation, whether I've got any comments on the presentation.
Any comments, maybe short comments from the panelists here?
Just one question. Is there one size of device or?
We don't hear you very well, no. Samir. The micro.
There's only one size and shape of device. I think that was the question.
Yes,
so it really is very straightforward. There's one shape, there's one size. The sinus needs to be 3.5 millimeters big distally to take it, but that's it. It's really not a complicated device. And as I said, it's a fairly basic development at the moment. The balloon and the strength of the crimping on the balloon are an issue, but very straightforward. So I think, in the interest of time, I'm conscious that we are running over or have run over. I'm just going to present very briefly some of the data just to convince you that there is some trial and data evidence to back this up. And it's been given a class 2B, level B evidence by the ESC for treatment of intractable angina. I think that may change over time. The major study to mention is CASIRA, which was a study that we took part in and published about 5 years ago, which examined sham versus reducer procedure in patients with good LV function generally, significant angina, limited revascularization options. A very carefully designed study where patients had a quality of life questionnaire, exercise stress testing beforehand, burden of ischemia test, and afterwards. And they had a sham procedure, so 52 in each group, 104 patients. And really, it was nicely designed and was quite surprising in terms of the results. So the endpoints were an improvement in greater than 2 CCS grades from baseline to 6 months. Secondary endpoints were reduction in ischemic burden, quality of life score, and ischemia on a treadmill test. And essentially, there was a big reduction in patients with more than 2, a big improvement in patients with greater than 2 clinical classes of angina. So 35% in the reducer group had a more than 2 percentage point reduction in angina burden, 15% in the sham group, which is also interesting, a big placebo effect here, and 71% had a greater than 1 class. So most patients responded. You'll also notice just about half of the placebo patients responded, which is also, as I said, interesting. And the mean CCS class was reduced by 1 grade in the treatment arm, not in the sham arm at 6 months. It was very easy, even in the early days, 100% procedural success. There were 34 adverse events, most commonly unstable angina, but small numbers in the procedural group and one MI in the reducer group. So I think this was really a landmark study showing the effectiveness of the reducer in patients who were appropriately selected. And I think something about selection, it's patients with left-sided ischemia. So the patients with right coronary artery ischemia don't seem to respond well. That's probably because the right coronary artery drains mainly via the middle cardiac vein into the proximal aspect of the coronary sinus. So a reducer in the middle and distal end is not effective. So it's mainly left-sided ischemia, circumflex and LAD. The reducer study enrolled 400 patients. It's still recruiting. We're still recruiting to it. 191 in the reducer arm. Again, it's prospective. There's no control arm, but again, it has shown a reduction in angina burden. The caveat to this, of course, is that it's non-blinded. It's not randomized, but it is sustained out at 2 and 3 years and appears to be effective. And I would say that having used this device in the patients in whom it works really rather well. It's fairly dramatic. It doesn't work for everybody, but in those who have a response, they have a significant response, such that they come off some of their anti-anginals, their exercise distance is definitely increased, and they feel much better. But it does not work for everybody. And there's probably some work to do in isolating exactly who are the responders within our cohort of refractory angina. Again, all of these within Reducer and Corsira show a significant difference from baseline. And again, the percentage of people with intractable angina at the end of the study is significantly reduced, again, by, from 70% at baseline to around 16% at 2 years. So there's a big signal for response rates. And it's very safe. As I said, even if the device does dislodge or embolize, we've had to snare them and remove them out, but they come out. It's in the venous system. There is no instance of stroke or embolic complications. You're on the right-hand side, the venous side. It's a really low-risk procedure. I think that underlies some of the last slides I'm just going to mention briefly. I'm conscious that we are close to the end of the session, but essentially, if you look objectively, this is Giannini's group in Italian of only 15 patients looking carefully followed with MR perfusion, but they show a real correlate, a scientific correlate of the theory of improving that endocardial epicardial flow. So increasing endocardial pressure and reducing the gradient. So on MRI perfusion, as well as noticing a reduction in ischemic burden by about 20%, they noted an increase in transmural pressure indices, correlating with that increase in perfusion. So it really backs up that scientific basis for use of the device. It improves exercise kinetics. This is again a 2-center registry from Tel Aviv and Germany looking at VO2 max and anaerobic threshold and oxygen slope. All of those indicators for cardiopulmonary fitness and ischemia in terms of oxygen slope all improve in many patients who have sinus reducer. But you'll see it's not true for everybody. There are some patients in whom it drops, but overall an increase in activity. And finally, I just want to mention in terms of just one more slide.
Yeah, okay, all right.
Yeah.
Go ahead.
One more slide, just to mention it briefly, that it may be useful for CTO procedures. We've used it in patients rather than putting them through complex retrograde CTO. We put a reducer in, and there is some evidence that it may be beneficial. So there was certainly a trial to be had comparing CTO PCI with a reducer in patients with left-sided disease. I'm going to stop there, but I hope I've convinced you that this is a very straightforward procedure which can be easily carried out. With careful patient selection, you can get a good result, and there is a definite indication of improvement in reduction of angina burden, improved quality of life, and there is potential for use in other difficult populations. The only thing against it is it's relatively high cost at present. It's around £5,000 if you use them in volume, but it's higher. It does need to come down, but it is something that I could potentially see being used in many populations, both here and in Africa. And with that, I'm going to stop, and hopefully we have time for a couple of questions.
Thank you, John. You have really convinced all panelists and maybe all attendees about the interest of this new technique. So I don't know if there is a short introduction, and then we go to the live session.
Yeah, John, I have at least a dozen of questions for you about this, but it's okay. I will do it. I will ask them to you privately, but it's a fascinating technique. We really apologize. We need to go to Jeddah for a live transmission. Otherwise, the patient will just get up from
no problem. I understand.
So
thank you for being so fast.
And let's go to see CTO PCI from Jeddah with Khaled Tamam.